Right. Welcome, welcome, welcome. I'm Amitabh Varshney, Dean of the College of Computer, Mathematical, and Natural Sciences. And it is my pleasure to welcome you to the keynote talk at the 21st Bioscience Day. This is an event which brings together a number of different units across this campus. The last time we had this event was 2019. And that was before the COVID era. And boy, does it feel good to be back in person. So let me first start by thanking all the different units on this campus that have come together to sponsor the entire events on the Bioscience Day. These include the Division of Academic Affairs, the Career Center, the Division of Research headed by Vice President Greg Ball, including the Office of Technology Commercialization. It also includes 5 colleges. These are the colleges of Computer, Mathematical, Natural Sciences, the College of Agriculture and Natural Resources, the College of Public, the School of Public Health, the A. James Clark School of Engineering, and the College of Behavioral and Social Sciences. So please join me in showing our appreciation by a round of applause to all of our event sponsors. Now, this is also the 13th annual Young Lecture. Dr. Eric Young, who has been a generous supporter of the Young Lectures, started in 2008. Dr. Eric Young is a proud science turf. He graduated from chemistry and biochemistry in 1978. And since then, he has been a very successful OBGYN, physician, as well as a real estate developer. In addition, he has been a proud supporter, a proud and very generous supporter of a number of activities here on our campus, which are related to bioscience research, education, and innovation. So it gives me a great pleasure to welcome Dr. Eric Young here. So thank you very much, Dr. Eric Young. And because of his generous support, we've been able to invite virtually veritable who's who list of outstanding speakers to the Young Lecture Series. These include E.O. Wilson, they include Francis Collins, they include the Nobel laureate Carol Greider, and today we are very pleased we have Dr. Joshua Weitz from Georgia Tech as our speaker. But before I turn over to Dr. Weitz, I would like to welcome Yanelin Perez. Yanelin Perez is a graduate student in working with Dr. Emily Bruns in the biological sciences, and she will be introducing our speaker, Yanelin.
I am really pleased to announce our keynote speaker, Dr. Joshua Weitz. Dr. Weitz's research focuses on virus-host interactions with an emphasis on trying to understand how virus infections of individuals can affect populations, communities, and even ecosystems as a whole. His group has been focusing on multiple aspects of these virus-host interactions, such as looking at the quantitative viral ecology of a lot of multiple different systems, looking at the viral ecology of marine systems, and looking at the advancements of bacteriophages therapy. In addition to that, he's also been looking at infectious disease dynamics, which leads into the talk to today. It's no surprise that his group has been so interested in COVID-19 and are actively researching various aspects of how the disease affects transmissions and what risk factors can be predicted through different models. Dr. Weitz received his bachelor's degree in physics from Princeton University in 1997 and his doctorate degree in physics from MIT in 2003. He then returned to physics later in 2003 as an NSF Interdisciplinary Informatics Postdoctoral Fellow and in Ecology and Evolution. He then spent 2 additional years in Princeton training as a postdoctoral fellow. And in 2005, he got a position as the associate professor in Georgia or at the University. Georgia Tech. I'm a little nervous. I'm sorry about that. He received tenure in 2012 and is now a Patton Distinguished Professor at Georgia Tech and often works with the School of Physics and the School of Electrical and Computer Engineering, in addition to Ecology and Evolution. Over the course of his career, Dr. Weitz has accumulated countless of awards for his research and teachings. Weitz is an elected fellow of the American Association for the Advancement of Science, an elected fellow of the American Academy of Microbiology, and currently holds the Charles Blaze International Chair of Excellence at the Institute of Biology at the École Normale Supérieure. Apologies for my French. And it was recently named a Simons Investigator in Theoretical Physics and Life Sciences. In addition to that, Weitz also received the Montgomery Blair High School, which is here in Silver Springs, Mathematics and Science Magnet Distinguished Alumni in 2018. So welcome back. With such a long list of accomplishments, it's a pleasure to introduce Dr. Joshua Weitz, and I, for one, am really looking forward towards your talk.
Thank you so much.
Yeah.
This microphone should work in the back. Is that right? Great. Thank you so much for the kind introduction. Also for saving the Blair High School Award. And that was really a treasure to return, though they had moved the school, so it wasn't quite like coming exactly back. Again, thanks for continuing to stay on with this event today. It's been very exciting, a lot of interactions. Obviously, we had to move a room, move a building, which I'm impressed was part of your contingency plan, so well done. And today I will be talking about ways that models and pandemic mitigation intersect, similar in some spirit to what you heard earlier if you were at the 2 to 5 p.m. session, but I'll try to capture a little bit of what I'm trying to do in today's talk with this image, which was a collaboration between our group, a scientist in my group, Dr. Stephen Beckett, an undergraduate artist at Georgia Tech, where we use one of the images from our risk assessment tool to try to, first of all, make the point that pandemics are not the same everywhere. They really are local in terms of their effects. People experience it differently, not just because of where they are in life, but when the pandemic hits certain regions, but also what we're trying to go after. The images below make it clear that our intention here is to try to get models as an interface to improve the health of communities. Right? So we actually have to make those models speak directly to the communities we're trying to impact. So today I'll try to give a talk again on this theme of pandemic models and mitigation, really trying to translate epidemic principles into practice. And there's a lot of folks that I need to thank. I will try to highlight a few as I go, but just to give you a sense of who's involved in my group now. We have a broad range of techniques, expertise, backgrounds spanning biology, physics, mathematics, and of course, anytime you work on any kind of interdisciplinary project, you end up even going beyond that expertise. So before I give you any information on the actual science here today and the way that we've done some of our translational work, I just want to make sure to acknowledge the funders, which come both from the basic sciences as well as more public health sectors, as well as foundation support. And the list of collaborators has obviously extended. And I, again, will try to highlight those individuals at key points where we've really reached out beyond our expertise, knowing where our gaps were to try to find ways to fill those gaps and be more impactful in terms of our translation. Okay, so I'm going to move everyone back in time a little bit, although we are already in that kind of framework with the theme here, early January 2020, in which there was one of the first statements that was public regarding a cluster of pneumonia in Wuhan. And very quickly, the word was out that this area was going to be closed. And the first case, at least the first recognized case, was found in Washington State just a few weeks after. Obviously, we have airport connectivity, air travel connectivity, things that begin in one place, just like in SARS, can move very quickly globally. Within the next month, there was a growing recognition within the public that this wasn't just something that was going to be restricted to China. Although many of us in the modeling community had been warning even earlier than that, we had surges in northern Italy, in the Lombardy region near Milan, and also in Iran. And soon after, as you know, this became a national issue as well. In early February 2020, in an effort to try to communicate some of both the research challenges and the public health challenges, as early as February 11th, we organized at Georgia Tech a coronavirus rapid response forum where I spoke mostly on the question of epidemic impacts and trying to do forecasting. But we also tried to bring people together from outside, including Trevor Bedford, some of you may know has been one of the earliest involved in recognizing some of the early strain differences and using that information as early as January 2020, January, February, in order to inform the development of the mRNA vaccines, as well as someone who's working expressly on this question of how do we develop vaccines. You'll notice at the screen above, we were in a very densely packed room, standing capacity only. Now, at the time, I don't think we were aware of cases in Georgia per se, but that is something that wasn't going to be happening for a long time soon after. In fact, one of the issues that my team began to work on quite early was the issue of asymptomatic transmission, something that Abu Gumel already referenced earlier in today's talk, and I will elaborate on that a bit more. One of the challenges with SARS-CoV-2 was the question of pre-symptomatic or asymptomatic spread. And because of that, many people, because of lack of awareness that they had no symptoms, and also because of the lack of testing, meant that large gatherings could be opportunities for far more transmission than might be conventionally considered to be the case. And so we tried to explain that both in social media postings, but also in this op-ed, which makes the point of how dangerous large events can be. When you don't know who's infected, you have an n-squared effect. You can imagine shaking everyone's hands, but in a room with shared air, especially those without ventilation, without masks, that can amplify and rapidly lead to large spread, like at the Biogen conference. Of course, very soon after that, in mid-March, there were these large-scale recommendations, restricting events to size 50, 250, in other words, trying to limit gatherings as a first step to try to limit the spread of this newly emerging disease. What is notable, though, despite all of this effort to try to inform that this wasn't going to be confined to one location, that there was the potential for airborne transmission and spread, is that by mid-April, optimistic forecasts began to materialize. And I just want to highlight this one to try to give you a sense and also set the frame for how we go to confront data and try to look forward into the future. What you can see behind me is one of the earliest forecasts from what is called the IHME, the Institute for Health Metrics and Evaluation. It's a well-known, if not one of the largest, certainly most influential in 2020 in terms of bringing together public data and making public policy relevant recommendations. And what you can see at the top here is that we have the moment at which they're making this forecast, and these shadows denote some of the uncertainty, and this is what they predict will happen by early June 2020. Now, predictions are hard, and as Yogi Berra said, especially about the future. And what you can see here with respect to some of these predictions is that the largest uncertainty was at the moment the prediction was made, which seems to be exactly the opposite of what you might expect to happen. You become increasingly less certain about some of what's going to go on in the future. Now, it turned out that they made this prediction and continued to make similar predictions, and there were other types of predictions that were made that you may recall the cubic fit. And if you don't recall the cubic fit, that was a third-degree polynomial in the spreadsheet that went at some point to 0. All of these models share the feature that at some point in the near future, and these were just projections that were made a month or another month out, they all made this prediction that this epidemic was going to grow in number and then disappear. And there was actually a rationale for doing it, but we can unpack even at the moment why we recognize that there was a fundamental gap here that made this curve prediction to be problematic. Right? And one of the reasons that this was problematic from the outset is that it was based on a notion in some sense related to some of the very earliest understandings of symmetries in epidemic outbreaks, something called Farr's law, who raised the question of why does it seem that there was a regularity in terms of the number of cases of smallpox in a particular locale that could go from 5 to 10 to 20 upwards and then go down just as rapidly. This notion was used and in some sense returned to during the AIDS epidemic in the mid-'80s, where individuals began to look at this slight curvature in the number of cases and interpret that slight curvature as the potential for this to turn around somehow on its own. And obviously, This is not the case. In fact, the number of confirmed cases in 1995 exceeded 75,000. And obviously, HIV/AIDS is a global pandemic. So just because we start to see some small bit of curvature in the number of cases doesn't mean that the epidemic end is near. One of the reasons why these models and these curves were problematic, and we recognize them as problematic from the outset, is that they were not necessarily mechanistic. They assumed that just these early cases were going to then be an indicator of the future, which also explains why there was no uncertainty a few months or weeks out, because the curves are meant to come and terminate. And so for that reason, all the uncertainty was at the beginning and there was no uncertainty at the end. So this is this notion of using Farr's law inappropriately to try to predict the end of epidemics. Nonetheless, it does capture something. There is a rationale for why epidemics go up and go down, but there were many features of COVID-19 which meant that this wasn't necessarily going to be the case. So what I want to do in today's talk is really pick apart three notions. First of all, to try to get some of the principles in place that we can talk about rationales for mitigation, talking about how are epidemics supposed to unfold, at least in some extent in theory. And then raise the question why COVID-19 has been so difficult both to predict in terms of what's going to happen next, but also, practically speaking, to control. And then finally, I want to unpack some of our efforts to go directly and bridge that gap beyond model predictions and forecasting to really try intervention efforts to try to use these same principles to turn these curves or turn the tide, both at a national scale and one at a very focused local scale. So I'll start with principles of how are epidemics supposed to unfold. As you probably recall, for those of you who were at Abu Gumel's talk, that modeling outbreaks depends on what we assume about populations. And of course, this depends on the disease type. Not all diseases spread the same way. Some are spread predominantly contact, sexual contact. Some may require a vector. SARS-CoV-2, from the very outset, fomites aside, we understood that this was going to be an airborne pathogen, which is why there was interest in questions of disease, masking, and so on. And because of that, we can think about ways to represent a population, dividing up individuals based on their infection status, whether or not they're susceptible, infected, recovered, and so on. And once we have some notion of that, we can make these choices. Do we want to represent every individual? Do we want to represent spatial populations? And there's a trade-off. The more we put into these models, the harder they become to parameterize. And we may lose some of the key insights that could guide simple policy choices. So what I'm going to try to do is explain the basic principle that underlies some of these extensions. And it's known as an SIR model. Abba mentioned it before, this notion that we can divide individuals based on their disease status in terms of susceptible, infectious, and recovered. And when an infectious individual comes in contact with a susceptible individual, there's some rate of transmission. And infectious individuals then over a characteristic timescale TI recover, so a characteristic period in which they're infectious and then recover. We can translate these into mathematical models, and the principal idea here is simply that susceptibles are depleted by the act of infection, moving into this infectious category, and there's a time scale TI over which they recover. And for now, I'll put aside the question of fatalities and all the other consequences that can happen. When there's an outbreak, it doesn't necessarily mean that just one individual or two individuals is inevitably going to lead to the infection of many, many more. And we tend to characterize whether or not a disease spreads or not, given a threshold criteria called R0 or the basic reproduction. And we can understand this basic reproduction number as giving us an indicator of whether or not this infection actually increases in number and then eventually declines, leading to the accumulation of recovereds and the depletion of susceptibles. And a few things to keep in mind here is that at the very end of the epidemic, not everyone is infected. We typically expect there will be some fraction of the population that won't be infected, even a disease that can infect 2 or 3 or 4 per each individual. And we anticipate this because at the beginning, nearly everyone is susceptible. And we can simplify what seems like somewhat complicated equations by noticing that the fraction of individuals someone might interact with that are susceptible, this S over N is essentially 1. Anyone that first focal case interacts with is going to be susceptible to this newly emerging disease, which was the case for SARS-CoV-2. And because of that, we can think about this change of the number of infectious individuals as being a balance between new infections and recovery, which are both proportional to this infectious number, this I. And you can see I'm taking I multiplied by a constant. This is nothing other than the biological sciences, a characteristic growth rate. And you can also see that the sign of this growth rate could be positive if this product is greater than 1, or negative if that product is less than. That product is nothing other than the infection rate times the duration. In other words, the average number of new infections caused by a single infectious individual in an otherwise susceptible population. It functions as a threshold. Right? But what's interesting is that you can look at that entire constant, and that's actually what you're observing. You're not observing this hidden variable. What you're seeing is the number of cases and how fast they increase in time. So you're observing one feature of the dynamic, and what you're interested in is this threshold criteria. And what links them is this generation interval, this characteristic time where people are infected. So all three of these are all packed in. And so try to make this a little bit more explicit. Here I've created a synthetic example where I have a disease whose R naught is about 1.5, and I've added some noise, and you can see this exponential takeoff. And in this next slide, I've changed it now to R naught of 2. And now R naught of 2.5. And there's no clickers. I think it's clicker channel 25, in case you're listening in. And I could ask the question of what I've changed here. But as you can see, these all look exactly the same. And I can assure you I can multiply two numbers by each other. So I know that these are 1.52 and 2.5. And you've all been told that diseases are worse when they have larger R naughts. But at least in terms of the case levels, these are all going up at the same rate. So something must be different. And what's different is that in the long term, although they look the same initially, the concern and the reason why modelers are often so concerned with measuring case rate increases and inferring the basic reproduction number is that if the number were larger, you can see the total peak is higher and it lasts for a longer time. Right? And this is this notion of measuring the speed, trying to infer the strength, and the strength ultimately determines, at least in theory, the size of the epidemic. And this is why, in essence, there's so much preoccupation amongst the modeling community of this R naught, whereas the public is often more interested just in the absolute raw number of cases. And that's what they see as their indicator. Okay. So this says that this value of R naught is not the only number that we should worry about. We have to worry about the speed, the strength, and the size. And later I'll even talk about something called dispersion. Okay. The other thing that we can realize is that there's this implicit link, and try to make this implicit link explicit. What you can see on the left and the right are two example case counts that are both increasing exponentially. On the left, we have shorter generation intervals, and the right are longer generation intervals. And at the outset of SARS-CoV-2, we're not quite sure how long it is that people are infectious. It's not just a question of viral load. Obviously, you need a critical viral load to infect, but it also depends on behavior. And some of that behavioral side is not something we can know from the outset. So if we make the assumption that the intervals are shorter, it takes more of these generations in order to recapitulate those case counts, whereas when the generations are longer, it takes essentially a larger reproduction number per generation, which in other words means that there's this direct link. Given observable like case data, if the intervals are shorter, R naught is slower, and if the generation intervals are longer, then R naught is also higher. Okay. This also helps you if you know this, which is a bit of a technical detail, but it's something that people didn't appreciate. You can read the headlines and interpret them. So this is a headline from Forbes: COVID-19 might be twice as infectious as was thought previously, and nothing really had changed. As soon as one hears that, the signal is maybe they've made a different assumption about the generation interval, how long it takes from one person to pass to the next on average. And what you can see is that if we constrain ourselves to a fixed growth rate, we've observed data. Like here, for example, if we make an assumption that the intervals are shorter versus longer, you can see that the inferred R naught goes up. So what happened here wasn't that there was any difference. There wasn't a strain replacement. It was simply a different assumption about how fast the disease was going. And again, that's an uncertainty we have at the beginning. Okay, and some of what we did early on was to try to make this explicit, try to tease apart these different assumptions, often conflicting assumptions, and come to a consensus that in fact we thought at the time R naught was about 3, which meant obviously this was a deep problem. This could infect many people, especially given what we understood about the fatality rate. All right. The other thing though I want to get back to in closing up this part, it raises a question: what does cause this peak? We've seen that IHME and many other models, including Farr's law, have a peak. They just assume things go up and inevitably go down. How do we get peaks when we try to use these mechanistic approaches to modeling epidemics? Initially, when a focal individual is infected using this R naught of 3, you can see in this population, there may be 9 people they might be able to interact with. In this case, they infect 3 others. And if that keeps happening, so for the most part, people are susceptible, these 3 become 9, become 27, and so on, and you get this exponential type of growth. But eventually, so many people are infected. For example, when 2/3 are infected, then of those 3 potential infectious contacts, 2 of those 3 are no longer useful because those susceptibles have already been depleted, and we term that herd immunity, right? So in other words, the spread of the disease uses up the very susceptibles it needs to continue to spread, and we get the point that we have a peak, but there continues to be spread afterwards. So what you can see here is that if I were to look at the susceptible fraction, now time is implicit, we start with all the diseases in which no one is infected, everyone is susceptible, and we get these different terminal outcomes in which there's a peak number of cases or peak number of active cases at any one point, and the stronger the disease is, the farther that we see the depletion of susceptibles. It's also important to keep in mind there's a concept called epidemic overshoot, right? In which we reach that herd immunity threshold, which if we had started off below that critical number, the disease would have come to an end. If we had vaccinated that many people, we would have been in great shape. But there are already many active cases, so we get something called epidemic overshoot. And obviously early on, there was this discussion we could reach herd immunity and then we'd be fine. Even that wasn't true. Because once you have herd immunity, you have many active cases, you still expect to see more cases. And unfortunately, as you can see, these numbers get very close to 1 once you get past something like 3 or 4. So this again reiterates the fact why so many modelers were concerned. And so many public health officials were concerned given the potential for spread. These are elegant mathematical relationships. And I have some of my math colleagues here, so I have to worry about not offending them. But they also, as we all know, including my math colleagues, know that we neglect many real-world factors, right? We have to make many assumptions to get these sort of inferences. So what I'm going to try to do next is unpack some of those, specifically in the case of SARS-CoV-2. For other diseases which have other transmission modes, we'd have to address and prioritize other factors. But I'll try to focus on the specific case. Why has COVID-19 been so difficult to predict and control? To do so, I want to show this network diagram just to give us a sense that not every individual is exactly alike. And of course, we know that with respect to heterogeneity and susceptibility, but if we look at the number of individuals who are infected by a focal individual, it varies significantly. And this has been recognized for a long time as this concept of super spreading. And it's actually important for us to keep in mind that we can think about super spreading as super spreaders. There's something about the individual, or super spreading, there's something about the event. Is it really the fault of the individual working at a low humidity meatpacking plant that they infected so many people, or is that something about that context? Right? And that is also very important when we try to address the issue. But nonetheless, certain diseases happen to have the characteristic that the number of secondary cases caused by a focal individual can sometimes be quite large, and we don't expect that in the simple models I just described. Right? And in fact, if you look at coronavirus as a particular case, as folks did and looked at these number of secondary cases, it was already known in that infamous choir practice in Washington State, which happened very early, there was a potential for large spread, and they were taking precautions. They actually had spread out physically, they hadn't shaken hands. So it was already a recognition very early on by February or March that there was a potential for many people to be infected by a single focal individual if the conditions were met. So thinking of super spreading rather than super spreaders, of course, there are certain modalities, including singing, that seem to be conducive to higher rates of spread. One of the first models that tried to address this was by Britain, essentially takes this notion of susceptible, infected, and recovered, adds an exposed category. And here, without putting any equations, I've tried to intimate the fact that there may be different structure in the community, maybe age or activity. And within one of these structures, those individuals are more likely to interact with each other, which you see in that contact matrix, which I've colored. And most of the way to the contact matrix is within that category. Right? If you make that assumption, what turns out operationally is that the classic predictions of this herd immunity threshold are above that which you predict by incorporating heterogeneity. So it seems, it may be paradoxically, that although the super spreading can lead to more spread initially, in the long run, when you have this heterogeneity and we divide individuals into different categories, it can actually lead to less spread. I want to try to explain that now intuitively. Why has that happened? If we think about a heterogeneity in terms of who's susceptible to infection. And that may be because of our activity, how many people we're interacting with, our vulnerability to disease. You can imagine that all of us are the same. And at this particular moment in time, I've divided the population not into groups, but in terms of this continuous susceptibility, where here's my mean, right? It happens to have a value of 1. And we can think of that value as modulating my likelihood of being infected. If I then ask, who is the next person to be infected on average, and how susceptible are they? The next person to be infected is more likely to be more susceptible than the average person. This is sort of the paradox, a little bit of my friends tend to have more friends than me. And that's an interesting side discussion we can have some other time. Why is that? You always have the sense, oh, my friends have more friends than me. That is actually a mathematical reality. In this case, the reason is that people who tend to be more vulnerable will be more likely to be infected. Therefore, those individuals being infected more likely than those on the left. In other words, you're taking this distribution and multiplying it by something that goes up like this and getting something greater than the average. But that means that the epidemic process doesn't just deplete susceptibles, it may sculpt the susceptibility distribution. In other words, depleting those individuals who are more likely to be infecting either others or be infected. That is the rationale for why the heterogeneity argument by Britton works, that you're pulling out people from one side of the distribution, and optimistically, maybe if those individuals are no longer infected, this disease could come to an end more readily than otherwise. You can see this in these model results in which we take this concept, and this is the limit of which everyone is homogeneous. Here we have this exponential. You actually change the very structure of the equations that people have long assumed work in the Kermack-McKendrick model. You end up getting a different nonlinearity. And the point for a general audience is simply that we end up structuring and shaping who is left in the population to be infected. Of course, if I make an analogy to a clerk at a supermarket, and that person has a lot of interactions. If they get sick and we put someone else in their shoes, then all of a sudden we're putting more people into that vulnerable position. So even this argument is fraught. So the takeaway here is that there's this unequal chance of being infected, and this can change the nonlinearity of epidemic models. It can also mean that there may be a rationale to have thought early that somehow we've run out of susceptibles because the disease was infecting so many other people we were testing, or that the most likely to be infected had already been infected. No, the problem with both of those is that there's another factor, which is it's possible that the reason why we're now at an R0 like 1 and we've reached that early peak is not because there was susceptible depletion, but because people are aware of how severe the disease is, and instead of interacting with 9 other people, now interact with far fewer. In this example, here was my R0 of 3. Here, there are many susceptible people, but noticeably, I've tried to place one individual here now who's been infected and died. And because of that, this infectious individual has decreased the number of interactions. Effectively now, we can reach a peak without depleting susceptibles. And that totally transforms the public health messaging and the consequences for what we do when we change behavior. This is the model that we then tried to communicate early on in response to claims that a peak meant the end of risk, and that the only way to get peaks was due to susceptible depletion, which is not the case. If instead we think of a model in which there are susceptible, infectious, recovered individuals, but also fatalities, and we're aware of the fatalities, and fatalities act as a negative feedback on how many interactions we have, and ask what happens in a simple model like this. What you can see in these models is that instead of having a single peak, you get oscillations. As individuals become aware of increasing fatalities, they decrease interactions. As interactions decrease, fatalities eventually decrease, leading to a rebound in activity and second, even third peaks. And as you know, there were multiple peaks. And of course, some of the peaks even later on have not necessarily to do with behavior, but also strain evolution and emergence of variants. The other thing that can happen is you can see asymmetries, that it can rise rapidly, but then hang out at a plateau for a long time. And one of the things we did early was to look at some of the asymmetries in case data coming out of both the US and globally, and I don't have to read necessarily the axis labels. The point is these are all in spring 2020, as you should be able to see we have a rapid rise and then more like a plateau. There's an asymmetry, either plateau or shoulder. And therefore, we made the prediction that we thought mobility and fatalities would have a certain characteristic shape. What was interesting is that they did more or less the opposite of what we expected to happen. Just to unpack this, the x-axis is mobility taken from Google mobility reports. The y-axis are fatalities in different states are listed in each of the colors. And what we expected to happen was that individuals would start to decrease their activity, like in Washington. Fatalities would start to decrease, and then they would begin to increase and maybe even substitute different kinds of behaviors. Instead, with the exception of Washington and New York, which more or less doubled back on itself, nearly every other state, individuals continued to increase their mobility even as deaths were at high levels or at plateaus. The only way we could figure out a solution to some of this, let's say, non-canonical behavior was to think of fatigue. Individuals begin to get tired or are unable to continue with lockdown measures or other types of low mobility measures because there wasn't the socioeconomic policies to compensate. And in these two images here, one of which deaths go up to quite a high level, in other words, getting to susceptible depletion levels, or here they stay relatively low because they've substituted mobility exchange with some kind of other activity like mask wearing. And in fact, there's quite a lot of evidence that there is in fact been fatigue and people began to get tired, whether because it was just too hard or because they were unable to continue that level of isolation and lockdowns. There's a deeper problem at stake though. So this is certainly helping us to understand some of the ways in which we need to think harder about behavior in epidemics, but there's another issue. And that one is, I feel fine. The notion that many of us might feel totally fine, but still have the risk of infecting others. One of the earliest indications this could happen, I won't even have a slide for it, was early examples in which people did contact tracing and then looked at the likely infector and infectee and asked the question, when did the symptoms arise? You might expect my symptoms should arise before yours. I infected you. This is called the serial interval, the time between when I am infected and show symptoms and when you show symptoms. It turns out very early on, there were evidence of negative serial intervals. The person I infected began to display symptoms before me. And they knew that I infected them because I came from Wuhan or I came from a city in which I mobilized. So it was already an indication that we had something quite pernicious that was at stake, which is this notion of pre-symptomatic or asymptomatic transmission. Just to give you two data points to keep in mind, these are CT values, so kind of looking at PCR-based viral assays, and I've put the asymptomatic and symptomatic days since viral peak load, peak at about the same time. There's not that much different, maybe a slight difference in terms of viral peak for symptomatic versus asymptomatic. Of course, there's another issue. We're here on a college campus. This is strongly age dependent. Young people more likely to have subclinical outcomes than our older individuals, which means that in certain populations, even the perception of what the disease may be will differ. So I want to just caution that asymptomatic spread is I really think a double-edged sword. And I think about this specifically in terms of the example of Ebola, which has anywhere 60 to 70% fatality rate at the individual level. With the exception of the 2014-15 outbreak, the majority of outbreaks are small. Although for the individuals are awful, they tend not to be issues of global concern. The reason, I think, is the following. Here I've put the fraction of cases that are asymptomatic, and probably it's about 50% for SARS-CoV-2. And obviously, fatalities per case will decrease, because if everyone is asymptomatic, we're not expecting these fatal outcomes. And if everyone is symptomatic, there's a higher chance of the case level fatality to be higher. Nonetheless, the number of cases is going to go the opposite way. If everyone is asymptomatic or nearly so, then there's a higher likelihood you're not going to change behavior and you're going to infect more than if you have an evidently symptomatic case where transmission only occurs after symptoms. We took this idea and combined it together in a very simple model. And it's something that we're still working on now, in which susceptible people become exposed. And we split this in terms of asymptomatic and symptomatic. There's a fraction P that are asymptomatic, 1 minus P that are symptomatic, and only the symptomatic individuals can potentially have a fatality and the rest recover. And for the most part, we're trying to think of this about ways in which SARS-CoV-2 operates, about a 1% fatality rate, which depends on demography and many other factors, but make one other difference, which is symptomatic individuals will reduce their interactions behavior by some factor delta, which may be high. right? So they are aware that they have symptoms and therefore self-isolate, quarantine, whether they do it themselves or imposed on by public health officials. And just one other point here is that one of the consequences, whether of vaccines, maybe even some strain differences, is this may change the fraction over time. It doesn't necessarily have to stay fixed. When we take this model and then ask the question, what happens at the end? How many people die in these synthetic outbreaks? You find paradoxically that the peak levels of fatalities occur at intermediate levels of asymptomaticity. Because on the right, if everyone is asymptomatic, we don't expect this is the common cold, which we haven't shut down society for. Whereas on the left, this is something closer to Ebola, in which there's very few asymptomatic cases. The individual fatality rate may be higher, but nonetheless at the population level, right? There's this gap between what's good, at least in concept for the individual, versus what's good or bad for the population. And this is true robustly whether or not we use R naught of 4, 3, or 2, and different levels to the extent to which symptomatic individuals may change behavior. Okay. This also explains to some extent what's going on with something like Omicron. If it's less severe, why has it caused this big peak and why are COVID-19 deaths rising? In part, here we're looking at proportion of asymptomatic in a model in which we run through an initial original strain and then ask the question of some variant which may have the similar level of asymptomaticity or even higher levels of asymptomaticity, and nonetheless, precisely because it's more asymptomatic, there's more transmission, which leads on net at the population scale to a concentrated period of high cases and high fatalities. What this says, in my view, is that what we try to do from the outset is try to build public support for action taking, but it has to confront this tension between individual and population level outcomes. So that's what I'm going to try to do here at the end. What does it actually take to try to build model-driven tools to prevent future pandemics? And I'll illustrate two examples, both of which we worked on quite extensively and collaboratively at Georgia Tech. The first one is, how do we just increase awareness of the spreading risk in events? How do we get people to be aware, who are not experts, that they may be in a crowd and someone in that crowd may be infected? And this was a priority of ours for most of 2020 when there wasn't this option to have vaccines, and which really was the question of social distancing, mask wearing, meeting outside, things that if people were aware of the risk, they might be able to take those steps to reduce their chance of being infected. And just to give you kind of a summary of this effort, we launched the concept in spring 2020 and built a county level website that was updated in real time every day, every county, and then went global. And over the past 2 years or so, we've had more than 16 million people visit the site. We've given over 60 million risk estimates, and we're continuing to work both on making this a global tool using this subnational software that we've just released called Local COVID-19 Now, as well as collaborating with behavioral neuroscientists to try to evaluate the ways that this awareness and nudging actually makes a difference in terms of behavior. And the key part of it is that if one were to look at the case counts, you can't use that as a proxy for prevalence. We don't use case counts as a way to say exactly how many people are infected. And this iceberg idea is about the right one, because about 5 to 10 times the volume of the iceberg is below the surface. And that's about where we were for most of 2020. For every documented case, there were somewhere between 5 and 10, at least initially, that were undocumented. And over time, the CDC recognized that even though there were about 16 million documented cases by December 2020, they estimated, using seroassays and some other methods I'm happy to talk about later, there were in fact been 80 million or more cases already by December 2020. Okay, so what do we do with that information? How can we translate this to something personal and relevant? If we just tell these case numbers, we're probably going to go to snooze and not going to change behavior. And what we tried to do was connect this to things that people might think of doing, going to a dinner party, going into a class, giving a lecture, obviously a concert, airplane, and so on. And the way we tried to think about this was imagine the risk that you take when you're in a small group in which maybe here 10 individuals, and one of those may be infected. But of course, as the room grows, the number of people grow, then the chance that one individual in that crowd is infected, and therefore there's a higher chance that that one case can become many. And the mathematics of this is nothing other than trying to get an estimate of the per capita prevalence at any given moment in a local region. And if we think of that as this value P, the circulating infection rate, which we estimate in practice from recent cases multiplied by this ascertainment bias, that iceberg idea I showed you a few slides ago. 1 minus P is the probability you're not infected. 1 minus P to the N is the probability no one in a room of size N or an event of size N is infected. And 1 minus that is the chance that one or more individuals is infected in that group. And once we do that, we can take case level data at the county level, estimate that P, and allow individuals to choose their event size actively online and get a sense of what the risk might be, whether it's a small event of size 10, an optional event of 50, 100, or even greater. And that was the premise behind this COVID-19 event risk assessment planning tool, which was not a good name, but we just were moving a little bit fast and didn't think that many people were going to use it. Turned out a lot of people used it. One of the things that happens when you build these kind of tools is that communication becomes a problem, and even sustaining it becomes a problem. What do you do with the fact that in certain days, 500,000 people come to the website and they have a lot of questions? Right? Also, what happens when you're trying to get the message out? Just because you're at an event doesn't mean that inevitably you're going to get infected, which was the misunderstanding that most commonly happened early on. We were trying to say the risk that someone might be infected in a group, and therefore you had the agency to make a change. You could wear a mask, you could meet outdoors, or you could even reduce group sizes. And we also had to try to communicate this at local level. So our team of collaborators ended up dividing up these sort of local TV and radio interviews. And this was also sustained by people behind the scenes. And this starts to become less of a usual academic venture, and more like running a startup. You have to have a web person, you have to have a comms person. You have basically are operating at scale in order to make sure that many people can access this if you want these very models to reach the public. And just to give you an indication of at times how insane this gets, this was just the number of requests for information on a particular day in July 2020. And I'll point out, because I know that comm staff are involved in making events like this happen, we had terrific comm staff that we became real partners with. Sometimes I know that comm staff were highlighting events that have already happened, right? Great news that already happened by researchers. These were real partners in making the research happen, because we were trying to reach people at scale, and learning how to do talking points and media prep became very vital to the very act of trying to do the model. The other thing we wanted to do was to make sure we understood what happened to all those eyeballs that visited the site. Right? The Kardashians can tweet something and get 16 million visitors probably in a few hours. Are we doing it effectively? Is it making a difference? What kind of difference is it making? So there's a group of cognitive neuroscientists at Duke who had used our tool independently to try to do an intervention. What happens if they let people know what risks were, or did imagination exercises, and then asked them whether or not they're willing to change an event? And we began to use the tool to ask questions. After seeing this, are you more or less willing to participate in an event of this size? And what you can see is that there's a need and want. There's a Maslow's hierarchy, as it were, of what people are willing to change. Small events, they're unwilling to change. Maybe because that's a family event, it's just not going to happen. They're going to see those trusted individuals. On the other hand, you can see there's an opportunity here to nudge people not to go to those large events. After seeing the site, they do express a change in willingness. We went even a little bit further and beyond that, asking people to imagine and try to calculate probabilities, and people are notoriously maybe not so good at calculating probabilities. Nonetheless, we asked them, compared their risk guesses to what we calculate at the current reality in their local district, and then asked questions about both how well did they do and what did they learn. And unsurprisingly, there was significant underestimation of risk at large events. Interestingly enough, there was overestimation at small events. So people didn't quite get how bad things get when you scale from small to large. And the other interesting thing, again, is that feedback can encourage risk aversion, but for the underestimators, and that is typically associated with large events. So I think we learned here, and this continues to go on both in targeted studies and field-based studies, where we just open the site up to whomever wants to be there, we're seeing some of the benefits, but also some of the limits of these nudges. Yes, we're raising awareness, but there are some limits to how far we can nudge and change behavior. There's one last example I want to do, and I think we started about 15 after, so I think I'm on time to give just one last example. Again, this notion of I feel fine. Right, a college campus in the South that's public and which is definitely going to open on August 15th, 2020, because that's what the state tells us to do. And those students are coming back. And the question is, what are we going to do about it to do our best to do right by them and by the science? And one of the things we decided to do, this is a collaborative effort, to think about testing not as an indication of how bad we're doing, as in yet another indication of failure, but actually as an opportunity for mitigation, using testing as a form of intervention if used properly and at scale. And of course, one can do this with large-scale PCR or rapid antigen tests. For various technical reasons, we end up using a saliva-based PCR test. And the principle, though, comes back to these simple models, which I'm trying to avoid some of the more complex models today. I'm happy to talk about them, but the principle is embedded in this SEIR model. In this infectious category, and for students, the risk of severe outcomes is very low. Certainly the fatalities was very low. So the question is, do we let them recover naturally, which might happen over the course of 7 to 10 days, or do we test them and remove them from circulation by giving them in isolation quarters, putting them up in a hotel, and we begin then to compete with these two routes. And you can estimate the impact here, how much we expect to reduce in theory has to do with the rate of testing and the sensitivity. Now, PCR is highly sensitive, but the speed matters, right? It's really speed that matters, and part of the reason why over time, and I think quite rationally, people have moved to these point of care antigen-based tests. But at the time, what we had available was PCR, but we knew speed matters. And one of the other factors, of course, is that none of these things are silver bullets. We need a variety of methods to try to make interventions. One of the big fights that faculty, myself included, tried to put pressure on our system to require masks in the classrooms in these common spaces, often between older, more vulnerable individuals who are not yet vaccinated and younger individuals, often in rooms that weren't quite yet well ventilated. And they reverse course. So we're starting off the fall with masks, with some social distancing, online learning. So we had a lot of factors that were already in our favor. And on top of that, we're going to layer in this asymptomatic testing. And the rationale there is simply that this first effort is going to reduce what we think the baseline R0 is. And the next effort of testing is really to get in the ballpark of about a week. This is on a campus of about 15,000, which represents about Georgia Tech. Here in the thousands of cases, here we're talking about in the hundreds. If we can get to the point where testing is competing with this recovery period, then we have a chance to make a difference. In practice, this was an asymptomatic surveillance program done at scale. We intentionally had enough resources that anyone who wanted to test, though it was not required and could not be required based on our charter as a state institution, we made it as easy as possible and rewarded people, this goes back to comms, with cookies and popsicles and so on, depending on the season, to try to make people, get people to show up. And obviously this was a collaborative effort. The lab-based work was developed by Greg Gibson and then a very large team in which it was donating saliva rather than using some sort of neck swab, throat swab or nasal swab, which is a little bit less likely to get large-scale interest. And typically we had 24-hour turnaround, still not point, but we get all the advantages of high-quality PCR. The other question is how much we should test. So in communicating this, we also need to explain why we wanted to test at scale. Here are two example outbreaks in a, that's called a dormitory or a fraternity sorority environment, which we talked a lot to those communities, 15 infected out of 104 out of 100. You can imagine what might happen if we do a small batch of tests and say, do we see an anomaly? An anomaly, maybe one individual just had an imported case, but we don't have an outbreak. Here, once the outbreak is big, we notice something unusual. Here, we're not going to notice something unusual. In fact, we probably won't notice it at all. So one of the rationales that we tried to say early is, what's the chance we observe 3 or more individuals in such a community? If the outbreak is small, we have to test nearly everyone. If the outbreak is large, we don't have to test that many people, but it's too late. In other words, we have to test a lot of people early if we're to try to stop outbreaks from happening before they take place. In practice, we ended up doing about 2,000 tests a day, identifying individuals, and also because we knew where those were happening, at least on the floor level and also roommates level, we could focus in and reinforce testing. And that's a topic for another day about the benefits of reinforced testing on networks. And although there was this peak, we knew where these cases were happening. And we very early got things under control. And beside that one point in a Halloween spike, both in fall 2020, in which there were no vaccines, we're able to keep things at below 1%. And going back to the super spreading idea, I just want to point out here that we had something like an 80-20 rule, that a small subpopulation of Greek houses and also residences were responsible for the majority of cases. In other words, these are like cruise ships on land. Once it gets in, even with the best of intentions, it rapidly spreads. And I just want to point out that again, after return, we were able to continue doing this through all of spring 2021. And this was meant to be a bridge to vaccines. And this program now has sunsetted after 500,000 tests. And it was definitely one of those things of trying to take this epidemic model, move together collaboratively, and get it into practice to make a difference. In practice, the majority of positive cases we identified on campus were through the asymptomatic testing. All those individuals were unaware, they went to get tested, found that they were positive. We ended up controlling outbreaks at lower levels than, for example, our peers like UGA, which was up to 9% positivity on surveillance testing, which any experts in the audience knows that's a very high number and not good. Okay, so this was the second example that I wanted to explain, that testing, asymptomatic testing, irrespective of symptoms, really can become a form of mitigation, not just an indicator of how bad things are. Using that intervention to make a change in behavior rather than just a passive indicator. So the last thing I want to wrap up with, in just giving these two examples, is really just to reinforce this central point. Yes, we have these elegant mathematical theories, which tells us what might happen, are often useful in the fog of war period. But at a certain point, we have to transition to action taking. It often takes some risks are involved, but certainly there are opportunities here, both of which I think intersect this question of human behavior, right? You're trying to get people to change behavior. You're trying to implement testing in a voluntary sense, right? That is not necessarily going to always turn out the same way depending on the community. And my view is that both also try to embody this question of how do we use modeling and theory as a form of action taking for public good. These are two examples. There are many more. I know Don Milton here at the School of Public Health has worked on a Stop COVID Now using UV light as a means of trying to do what masks are doing, but without wearing masks. And many other groups, Abu Gumel and many others, have tried to make these kind of impacts. But there really is more to do. One of the key features is going to be how do we institutionalize many of the action takings that have been put on individuals. And yes, as individuals, we should still have access to this data in order to take actions that might improve our health. But we're going to have to institutionalize them in the long term if we're to try to get a better normal. Not just go back to the other one, which we're very vulnerable to pandemics, but try to do those things like having healthy air in the same way that we don't tolerate levels of pathogens, chloroform, bacteria in our water. What are we going to do to make it so that individuals who may be vulnerable are lower risk of having exposure to viral pathogens in the air, using things like testing as a form of mitigation. Think of these as public resources and public goods. Also using passive indicators. We're not testing at scale anymore, but there's opportunities in wastewater detection to try to make a difference and then use that as a cue to take public health actions. And finally, things like high impact masking, whether it's in subways or airplanes, or particularly in nursing homes, long-term care facilities, which we worked on. I haven't talked that much today, in which those are circumstances in which there's a huge disproportionate gap between the number of cases and number of fatalities, and selective use of high impact masking can also be essential. And today I haven't talked that much about vaccines. Obviously, this is a game changer, but as one can see, it's not the only game that we need to change. We don't necessarily work on the vaccine side. There's a big opportunity even there to ask questions, not just how effective the vaccine is, but how do you translate a good vaccine to one that has higher coverage and that we update and people want to continue to take over time. So with that, I just want to have really two last slides. Some of the lessons learned here is that there is a huge interdisciplinary frontier between human behavior and epidemics. In some sense, the epidemic side was the easy part. The human behavior side is perhaps even harder. And if we're going to do that, I think we need to think about instruments And there's obviously investments being made by the CDC, Rockefeller Foundation to try to have public-facing instruments, things like weather maps of the kind that we did, which really are in the situation of nowcasting, but nowcasting information that is relevant to individuals. Instead of telling them cases per 100,000, we need to tell them things. What is the risk of potential exposure? What are CO2 levels in a room that are tolerable? And try to have those be available and accessible, mobile web, that you can make individual decisions. And fundamentally, I think this needs a data-driven communication approach, one that's transparent, that is honest about what we know and what we don't know, and that is timely. And as you can see, this becomes an investment that individual researchers, not all of us have to do, but some of us may want to do if we're going to try to make this kind of gap. And finally, I want to maybe step back even further. There's often a bit of a dichotomy. Are we doing basic research or are we doing applied research? And we were talking a little bit about Vannevar Bush. This is the division even of NSF. We have our peer research, we have our translational research. I think what many of us are trying to do in this space is what is termed Pastor's Quadrant by Donald Stokes, which is really use-inspired basic research. There is a clear use, but we need to advance the basic science if we're going to try to do the translation in real time and make a difference. And I think in that space, there's quite a lot of opportunity and need for biologists, epidemiologists, public health, engineers, social scientists, and so on to continue to work together to make sure that these lessons learned are not just wasted through burnout, but sustain the way that we approach COVID-19 now and pandemics to come. And with that, again, thank you so much for joining me late in the day, in a different room, in a different building. And thank you to Joyce and family for your support of this series. Happy to take questions. Yes, and I don't know if there's a circling mic or if I'm supposed to pass it. Maybe Eric can help. I don't see it standing, so here you go.
Thanks for that. I had a question on the behavior feedback part of the epidemic, and it seems like one thing that would also be really interesting is, yeah, you might expect a reduced movement if you're seeing a lot of fatalities in the news, but there's also, if an epidemic is spreading quickly and you have a lot of asymptomatic cases, would you not also have the probability that the first couple of cases that people would know close to them turn out okay? And so you might have that opposite sort of behavior happening where, you know, on a college campus, you're like, oh, well, all of my friends got it and they're all fine. And so that's maybe a faster form of feedback than because the fatalities take longer to accumulate.
I'm just going to agree with your point. I have a longer piece that I've been working. The question is really a perception of experiencing different epidemics. We didn't all experience the same pandemic or epidemic, and certainly at Georgia Tech, I'm sure at UMD, individuals whose roommates or friends got sick, got infected, got over very quickly have one perception. And this is another reason why this asymptomatic fraction is so pernicious, because you can then increase activity because you think that I'm safe, I'm going to turn out okay, and you may well turn out okay. Those same individuals, we're thinking about, for example, our Thanksgiving break. We thought very hard about trying to even increase testing. So what we were worried about was less the individuals on campus, but their return home to older family members, parents and grandparents, for precisely that kind of reason. Their experience had been the individuals who were infected predominantly had mild cases, or maybe didn't even know they were infected. So I think this gap of changes with time and with age, I showed you that prevalence of asymptomaticity early on. So it's absolutely true that in an older individual's perception, grounded in the reality of peers and peer groups, and also the risk with age is quite different than a younger individual. So unless we think about connected communities, we could end up in the very circumstance you highlight. I don't have an answer for it, but it's a legit another aspect of the feedback that we'd have to think about as we go beyond this one group to different ages. There was a question on this side.
Okay, I'm prepared to step on the third rail here.
Okay, I don't know what that rail is, but you're going for it.
You had the opportunity to be a social influencer in a community of rational people, the university. Evidently, you were also able to exert that influence in a state whose governor and legislature were basically acolytes of a presidential administration who totally rejected science because it didn't fit their political philosophy. How were you able to accomplish what you were able to do, and the rest of us, NIH, FDA, CDC, couldn't do it nationally?
Okay, so in Georgia, when we began to operate, my hope was that we could work as a modeling community with state level government on committees to try to inform that committee, which would push information up to governor levels. And it was clear very early that if we had some ideas, the best way that we could translate them was to talk directly to individuals. The other advantage of being a bit outside of conventional public health institutions is that there's something called academic freedom, which allows me to say things if we make the choice, and in fact, can be used and leveraged for a lot of power. So I think one of the advantages some of us had outside, and let's look at folks like Shweta Bansal here at Georgetown, who did a vaccine map and database that in some sense outcompeted the CDC's own internal resources for a while. Lauren Ansel Myers from UT Austin, the JHU dashboard, which was again, outside of government circles. When we built some of this early version of this prototype and we approached the CDC about whether or not we wanted that potentially to go as an institutional resource. I always viewed it as something that could be an institutional resource. The time it takes to get a website cleared is not compatible with the time we felt it would take to try to make the difference. So we had to then build up a comms team, use social media, spend our time effectively, I think, going directly to individuals, write op-eds, go on both local, national radio and features. So you're asking, why did that happen? Sometimes a few people acting nimbly can be more effective than larger bureaucracies. That's just how it goes, especially in the public health space. Now, with respect to some of the politics involved, we wanted to reach everyone. So we tried to speak as directly as we could. I live in a purple state, and we wanted to make sure that people in Southwest Georgia or in rural parts of Northern Georgia who may have different political affiliations, nonetheless have the access to the same information as people in Atlanta, Georgia. So one of the things that I wanted to do very early on was make this a county level database and not have things be localized at the state, because state is too coarse a descriptor for what was going on. So I think that really was the insight that we had to move to counties. Love to even go beyond, but that's where the data stopped us. And because of that, I think we were able to access and speak to people individually. And when we look, I didn't show the data on partisanship. More recently, I talked about nudges. We have reached more people who self-describe as Democrat, left-leaning than they do as Republican, right-leaning. Nonetheless, to the extent they showed up at the site, when we actually look at their response, it's very similar. So the nudges are working at similar rates, but people aren't necessarily reaching it. And that is one that I think people have talked about, information echo chambers in which you're sort of hearing your own information. So throughout, we tried to have the same message irrespective of who we were talking to. And I think that is critical, because ultimately, just like it wasn't going to stay in China, given the asymptomatic cases, it wasn't going to just stay in Italy or Iran. It wasn't some exceptional thing somewhere else. It wasn't just going to stay in Atlanta. It was also going to be hitting in rural places. And likewise, if we go to Maryland and think about Garrett County, some of that misinformation on the northwestern part of the state, it's fatal misinformation in the end. Early on, now I'm giving you, stepped on the third rail, but I'm giving a long response. Early on, there were severe disparities in terms of socioeconomic, but also race in terms of a vulnerability to being infected and having a bad outcome. And for many and most diseases in the United States, you have to look, what is the gap between Black and white, Hispanic, non-Hispanic, white? And there's almost inevitably a gap in terms of outcomes. For COVID, age was always the primary factor, it was age, but the other one was there too. What has been notable is if you look now at the fatalities at per 100,000 in let's say, counties that tend to be Republican versus those that tend to be Democrat and vote one way or the other, there's now an increase in fatalities. I think there's a report of 78 increased excess mortality per 100,000 in a Republican voting county versus a Democrat one. And I have to double check that. I read it this morning, but I may be off on the number. There has been a gap in vaccines and therefore behavior. And so what we see is the failure of a national public health dialogue so that we're getting for original sins of infrastructure gaps, one problem, and now a new misinformation and polarized challenge. And we have to reconcile both. And maybe as my last point here to close out, AAAS has a mission of advancing science for everyone. I've been on certain dialogues where you're trying to advance the understanding of science in every aspect of American society. That should also hold for our public health messaging. So what we tried to do on the asymptomatic testing, I wish we could have done more, but bureaucracy, whether FDA or state level, we did as much as we could do at the time and the resources we had. This risk one is one that in the long term, I think there's still an opportunity to bring this to more people, and we're happy to have dialogue across the political spectrum to make sure that happens. So thanks for the question. I hope you don't mind my long answer.
On that note, thank you very much, Joshua. What a fantastic lecture. So what I wanted to do is, first of all, take a moment to, just like Joshua, thank our communications, development, and the event planning staff for doing such a fantastic job throughout the day, including this young lecture, for carrying out what I thought was a fantastic bioscience day. So thank you very much. Please join me in thanking. Now, I would like to also thank our distinguished speaker, Dr. Joshua Weitz, with this token of appreciation from all of us here at the University of Maryland. Thank you very much.
Thank you so much.
And finally, thanks to all of you for making this such a nice day. Thank you.